Welcome, my name is Nicky and I'm the Adult Services Officer at Clapper. Together with my colleague Kenny, we make up the Clapper's Adult Service Delivery Team. Welcome to the latest Cleft Talk panel discussion brought to you by Clapper's Adult Services Project, proudly supported by the VCTC Foundation. Cleft Talk is your opportunity to learn more about the topics that adults born with a cleft across the UK told us that are important to them through the Adult Survey and Roadshow. We hope that you find these panel discussions both entertaining and informative. Remember that you can keep up with the Adult Services Project online, including watching this and other panel discussions again at www.clapper.com/Adult Services Project. You can also join this conversation on Facebook at www.facebook.com/groups/ClapperAdults. Today on the programme, we are discussing one of the most major procedures associated with cleft care, jaw surgery, also known as orthodontic surgery. Jaw surgery can make a big difference to how you look and how your jaws work to help you eat in, but the treatment and surgery involved is significant, meaning this is a big decision to make. Today, we hope to shed some light on this treatment so that if you're faced with a decision to make, you feel well informed and have the facts you need to help you ask the right questions to help you make that right decision. It is our pleasure to welcome our panel guests, Kanwalraj, Rachael, Arthur and Karine. Before we get into the discussion, can you please briefly tell us a bit about yourselves and your background?
My name is Karine Edme and I'm one of 4 clinical psychologists in the Addenbrookes team with regional service, so we work and cover quite a sector. My background, so I've been with the Cleft team for 2 years and a bit, and my background is more in traumatic family relationship and safeguarding.
Brilliant. So my name is Rachael Willis. I'm an orthodontic consultant based here at Addenbrookes and I work predominantly for the Cleft Lip and Palate Service. So in my training I've qualified as an orthodontist and then gone on to do some further training in conditions and supporting patients with cleft, for instance. It's something that we're very passionate about, so love to do. We're a brilliant team here.
So I'm Kanwalraj Moar. I'm a cleft surgeon. I've trained in the whole remit of cleft surgery, from treating the babies all the way through into adulthood. And then in particular, because I'm from a maxillofacial background, I do a lot of the bony surgery, so that means the jaw surgery, things around teeth, bone grafts, that sort of thing. And I've been at Addenbrookes now for 6 years, so it's quite a while. Yes.
Oh, brilliant.
So I'm Athar Ali Syed. I'm actually a member of the ARC, which is the Young Representative Committee for Clapper. I had my jaw surgery back in July of this year, performed at Guy's Hospital. And in terms of background, I'm actually an auditor who works for a pharmaceutical company based in Cambridgeshire.
Oh, brilliant, thank you. Welcome to you all. Okay, so we're going to start with our first question. This is to Kanwal. Can you start by giving us an overview of what jaw surgery is and who might jaw surgery be considered for?
Okay, so what we call jaw surgery or orthodontic surgery is a treatment for moving the jaws into a different position. And it's not exclusive to cleft. In fact, the majority of the patients who will have jaw surgery don't have a cleft. However, what we find that in patients who have had cleft, they will often have a smaller upper jaw, which means that they have a disparity or a difference between their top and bottom teeth. So we would hope in what we would call a standard occlusion, or the type of occlusion where the teeth meet together, that they would meet top teeth in front of the bottom teeth. Sometimes what we find in cleft patients, it's the other way round, so the top teeth are behind the bottom teeth. That's not necessarily a problem. You know, you can function perfectly well, you can speak, you can eat. It depends on how much difference there is. But in addition to that, if you've got a small top jaw, it may affect appearance, and this is something that quite a few patients will come in and say, I don't like my profile.
Mm-hmm.
And that then starts the conversation about what is it that they don't like about their profile and what's the underlying cause of that. So they may come in and say, I don't like my nose, and then when we explore a bit further and look at it, we find that actually it's because their top jaw is a lot smaller. There are other variations, so sometimes you can have a small bottom jaw, sometimes you can have a big bottom jaw, but for the majority of patients with cleft, it's around having a small top jaw.
Mm-hmm.
So that's sort of who we'd consider it for.
And what is the benefit of having jaw surgery?
So the first thing I'd say is it's elective,
Yeah.
which means that it's absolutely on patient choice. You know, if a patient comes to me, if they're not saying they're interested or that they're not defining a problem that I think, yeah, that's something we can change. If they come to me and say, I'm really, really happy and I can see their teeth are the wrong way round, or that they've got a profile which shows me that they might have a small top jaw, if they're happy, I'm not going to give them any treatment. I'm not going to say to them, you need treatment, they're happy. So it's a very elective sort of procedure. But I will get patients coming in saying they can't chew or they can't bite, so they'll bite a sandwich and the filling will get left behind, and they don't like eating in public, or they may struggle somewhat with their speech, with the placement of where they put their tongue, so they feel that they've got a little bit of a lisp. And then the final thing we mentioned already is there may be something around their appearance that they're not happy with, that they feel slightly uncomfortable with. And actually, one of the questions I will ask is, how do you feel about having photographs taken? How do you feel about profile photographs? And that can often give us a clue of really what it is that they think about themselves in that context.
Yeah. And what age do you have to be to consider having jaw surgery and get it done?
So, adult. But I would always say I would want my patient to have finished growing by the point of surgery. The treatment in the run-up, which I'm sure we'll go through, takes a few years, but at the point of surgery I want them to have finished growing. So usually for boys that's a minimum of 18, for girls you can get away with a little bit younger, but we usually say around 18. Again, it can be tweaked slightly depending on the surgery, but if we're correcting the teeth being the wrong way round, we need that bottom jaw, the lower jaw, to have stopped growing. Unfortunately, it's probably the last bone to stop growing, so you can have the surgery and then grow out of it, so we don't want that to happen. In terms of upper age limits, I probably wouldn't go beyond 50s, but I would suggest that recovery and healing is a lot easier earlier. So if it was something you were going to consider, the sooner you do it, the better.
Yeah. Brilliant, thank you.
Now, obviously, it is quite a big thing to consider, you know, as you're saying, kind of what's involved in the surgery itself. Coming to you for this next question, Rachel. At what point in your care, obviously we've discussed the point at which the treatment would happen, but at what point in your care might you realise that you could be a candidate for this surgery?
So we are, as orthodontists and surgeons within the Cleft team, I suppose we're monitoring patients from infancy. So there might be some patients that actually their parents notice a discrepancy in their bite or their jaw relationship when they're little. And we talk about to them that there are things that can be done later to change it. So they may grow up having had it talked about as something that they could have or should be, or maybe that's part of their treatment. That's not the case for everybody. Usually around the age of about 15, when you've got most of your adult teeth, we can have a pretty good idea of if you have the type of bite or difference in your tooth position that might warrant correction with a jaw procedure. So at that stage we start to talk about it for patients who might actually benefit from that type of treatment. At that point in time, it's very much, this is something you could consider, you don't have to do it, and just start exploring, perhaps with the help of the rest of the team and Karine, what it might involve and if somebody's interested in it. If your teeth are close together, sometimes we can manage just with braces, so we have a good idea around the age of about 15 if that's possible or not.
And obviously we've spoken a fair bit about upper and kind of lower age limits for having this treatment. But if it is considered to be an option for somebody, and obviously they speak with yourself, Karine, as well at that point, at what point would you normally expect someone to be making that decision?
Most youngsters would do it around, once it's mentioned to them that could be a possibility, and they are, they've had previous surgery, they are in the middle of their pathway, so they tend to consider it then. But actually, some of them are at that point in time are not interested. It's not the right thing for them. They have other things to do. They might be really fed up with having had so much treatment and surgeries that they want to break, and they might go back to it later. So in terms of considering it, I would say that that's around age 15 for the majority. and then later for the ones who maybe that wasn't mentioned to them, or maybe that wasn't an issue and it has become one later on?
I think there are a few key points. I mean, we start probably thinking from a toothy point of view at around 12. We start picking up and thinking, which way is this patient going to go? Is this something we're going to have to consider? Because at some point we like to straighten teeth. It's one of the things we like to do. But we wouldn't necessarily push it at that age, because actually you've got a young child there who wants to enjoy their life and get on with things.
Yeah.
So 15 is a point where we need to be starting to think about decision making. But actually, if a patient says to us, I don't want to do this yet, I don't want to discuss it yet, they're not putting themselves at risk, they're not missing an opportunity, they can come back to us. But the flip side of it is, for patients who really, really want to have it done, they want to get into the system as soon as they can, which is around 15. So that's why we start thinking about it, that sort of age.
And I think there's a point you're saying about that's a surgery you can have at, in a way, around those brackets, but at any time, because sometimes we can pick up on parental anxiety about would that treatment not be free once the our youngsters leave the pathway at 20. And actually we've had several questions around would we have to go and do it privately. So there are questions around this that we can reassure families that there's no pressure in terms of when you have to get it from the system. It's based on what you feel like and what is your need at this point in time, in terms of when you want to have it. So that's quite important that families remember not to put pressure on their youngsters to have it done now, because after that you're not under the pathway anymore. You come back as an adult.
Definitely, and I think that's really empowering for people to know, because as Ricky mentioned, it is a big decision to make, and particularly, if you're 15 years old, you just may not quite be ready to make that decision, and I can imagine that can be incredibly frustrating for parents, as
The
well.
other thing to think is that sometimes this can potentially be the first surgery which our patient will be consenting for themselves, that they're going to be signing for themselves. And it's a big one to go for. It's not like I'm going to come in and have a small something, my ear pierced or something. It's not that. This is a big surgery. So we have a lot of conversation around it. It's not just come in, make a decision on one day. We have multiple appointments, and the amount that is necessary for each individual patient. So if a patient has got more questions, and they go away and think, I need to ask more, I want them to come back to me and ask more. I don't want them to feel that they've got to make the decision on the information they've been given so far. There is always more opportunity to ask again, and that's really important in this process.
And I think, as you're saying, it's also a new step for them, because all the surgeries before were pretty much black and white in terms of you need this or you need that. And this one is the harder one, because actually this one is that you don't need it, but you can have it. This is what it would do for you, but you can have it. And therefore that's a huge transition to make for the young people that at this point in time, where are they? So they have what they're feeling about themselves, but their mum might be feeling something, their dad might be feeling another thing, the friends might be, giving other advice, and then that's really difficult. How do you make such a big decision if you're not sure, and actually the people around you have all different perspectives?
Definitely. And I remember at that age, myself, and I had the same decision to make, and you hear lots of conflicting things from different angles, and it is really hard to make that decision. But I think asking questions, as you were saying, is really important. I used to have a notebook where I write things down and bring them to appointments, which I found worked really, really well for me.
Young people now
It works for us.
Also in your phone, you have that section on your phone. You can, because you can have something that pops. You're on a train, or you're somewhere. You have, I'd like to actually ask that, and so you can pop it on the notes, and you can then come, and we don't mind you looking and saying these are the questions I had, and we welcome any question. Really, really welcome any question. There's no silly questions. I think that's really important.
Yeah. The other thing is, sometimes we'll get asked a question which is surprising, and we're like, oh, never thought of that before. But then that feeds into the future of what we tell other patients. So any feedback that we get, anything around thought processes of how you make the decision and how you felt after the operation, any information like that is fantastic for us as well, because it means we use it in our day-to-day practice. So the next patient that comes in, we can give them that back. So it's a constantly evolving process that the more conversation we have, the more we can give to our patients.
I think at that age it's really important, because you say some 15-year-olds are not quite at that point where they feel comfortable and confident to make that decision, but also making sure they're aware that it is not an absolute all or nothing. It's that if you don't have this, you can't have anything. And we do have some patients where we just do some simple orthodontic work to improve aesthetics of their top front teeth, and for them that at least that's something, and it takes the pressure off, and they come back later when they're a little bit older and perhaps are in a different position and have different priorities of what they would like.
Definitely. And now this is kind of a question for everyone. I'll start with you, Karine, but definitely open that out to everybody. You were mentioning before, obviously, you know, it is a lot to kind of, and you were saying before about, you know, consenting to your first kind of procedure, and it's quite a big one. Obviously, we'll talk shortly about kind of what the process is once you say, you know, I think I might like to go for this. But before we get there, what are some of the potential risks and side effects of this surgery?
If I consider from a psychology, you know, I leave Cameron for the surgical risks. If I consider from the psychology, I think the main risk, you know, the main question that our young people have is that, you know, once I do it, I do it. Would I get the results that I want to get, or that I believe I am going to get? So a lot of the work we do in preparing for the surgery is around expectations. I think that's the most important one, because for some of them, when, for example, it's going to be a functional, so the appearance is not something that they would have a surgery for, but actually they are really struggling with how they bite or some of their talking, then we have to work with them is that the side effect is going to be your appearance is going to change, and it's preparing for the what ifs, preparing about what you know, what would be the best, what would be the worst, what would you have to see to be very happy or very unhappy. So I think from the psychological perspective, I think it's the unknown. I think that's the one that we work a lot on, in terms of the unknown. Of course, there's the surgery and tolerating the surgery. Young people that are considering that surgery, if they're in their teen years, there's a lot of usual things that go on with teenagehood as well. Teenagehood is not the easiest time, and sometimes you can have some additional mental health, you know, sort of difficulties that are mainstream to anyone, not particular to cleft, but actually you can have anxiety about coming to hospital, you can have you know, some depression, and those are the kind of things that we work with the team. It doesn't stop you having the surgery, but it might increase, you know, how, you know, complex it's going to be for you. So we'll support you to go through that as a team, and we don't want, you know, your anxiety to be heightened or your depression to be deepened. So we support with that. So I would guess those are the main psychological, you know, risk we would see in terms of the surgery.
Teeth next, or surgery next? Teeth next.
Teeth. For a lot of patients, they may have already had some orthodontic work, or some work if they've had a bone graft beforehand or afterwards. So some of it is to do with just being in the system for a long time, prolonged treatments, which carries with it some additional risks, difficult to clean around braces, perhaps slightly higher risk of getting problems like gum health problems and decay, things like that. So making sure you're well supported by your dentist. As an orthodontist, we worry about shortening of roots, so when you're in treatment a long time, the root lengths can get a little bit shorter. And sometimes around a cleft site, the roots are slightly different shapes and sizes anyway, so we're aware of that and consciously making efforts to try to minimise risks. From an orthodontic point of view, at the end of any treatment, whether you had jaw surgery or didn't, we talk about relapse, so teeth going back the way they came from, things getting misaligned again. So retainers are a huge part of brace treatment now in a way that they weren't historically, and just making sure that people are aware that they're going to need to wear something for us, please, to prevent teeth changing.
The surgical. So this is where I big them up but try and make them little at the same time. It's a big procedure, it's a big treatment plan, and when you put it all out there for a patient, you can see that they feel the pressure, and they're like, that's massive. But then when you put it in the context of how long they're going to be alive, and you come back to a patient that's a bit further down the line, and they go, yeah, it wasn't the easiest of things to do, but actually I'm very happy I had it. So I need to put it in that context before I start talking about risks. That I would say pretty much all the patients that come through will say hard but worth it. So that's something to really bear in mind. So when we think about it, we've talked about length of treatment coming up to it. there's a short hospital stay. It's not a long hospital stay, actually. Probably, for most patients, 1 to 2 nights. But I always say those first few days, that first 2 weeks, are hard, yeah? And it's best to make friends with the sofa, the TV, and whoever's looking after you, usually mum and dad or relatives or friends, because all you want to do is eat, sleep, maybe watch a bit of TV, but just take it really, really easy for that first 2 weeks, and take your painkillers regularly, because it's going to be achy and sore, okay? You're going to be on a soft diet for 6 to 8 weeks, which is not fun. And when we say soft, we mean proper, sloppy, no chewing type food. And this actually is quite tricky, because one, it doesn't taste as good, and secondly, when you're healing from an operation, any operation, and particularly bony operations, you need more calories. You need to eat more to recover and heal. So you're struggling to eat, but then you need to eat more. So you're going to be tired. And I always say, have an expectation of being quite tired for the 2 months while that bone heals. You're not going to be back to going up to the gym and doing all of that straight away. You know, you might get back to work after 2 weeks, depending on what you do. If you're doing an office job or school, you could get back to that. But if you're a carpet fitter or doing something really physical, like working in a warehouse, you might need 4 or 6 weeks off. So just bear that in mind. And the other thing is, sometimes I have to add some extra bone from the hip. So if we do that, it doesn't lengthen the recovery period, but it just makes that recovery a bit more intense, if that makes sense. You're going to be sore. So as I said, regular painkillers. But actually quite a few patients come back and say it wasn't quite as bad as they were expecting. And that's because there can be some numbness associated with this. So there are nerves that come out in the cheeks and into the lower jaw that will get bruised during the procedure. So that numbness in the top jaw particularly usually goes. In the bottom jaw it can be permanent, or a small amount can be permanent, but we discuss that in detail around when we do the consent. It'll be swollen, so, and that swelling starts over the first 48 hours and then it generally drops off. And hopefully by about 2 weeks, the only people who will know that you've had the surgery are yourself and the people close to you, because you can feel that you might be a bit, you're like, oh, this feels a bit different, but someone looking at you wouldn't necessarily know. Okay. Change in appearance. That can be a big one, and actually our patients tend to cope with that really well. Mum and dad sometimes don't, so that's just something to bear in mind, okay? What else? It's an operation, so you can bleed a bit during the operation, so that again would make you very tired afterwards. In terms of complications specific to this, sometimes we use metal plates to fix the jaw, and sometimes they need to be taken out later on. Not always, we leave them if they don't cause any problems. The jaw can try and move back to where it came from. We've talked about tooth relapse. The same can happen with the jaws. So that means sometimes we use elastics afterwards to hold things and encourage things in the right direction until it's healed. And we also say, once all your braces off, you must wear your retainers. And we say those retainers are for life. You know, if you don't wear them for life, you risk going back to where it came from. With cleft patients, and this is specific to cleft as opposed to non-cleft patients, patients that have had surgery on their palate, so for a cleft palate, their speech may change with having jaw surgery. And what we do before we get into this pathway is we look at how well their palate works, so that we can have a discussion around, if the speech changes, what can we do for it? And that leads me to thinking about what other things may change. So with the appearance change, speech change, we may need to do further operations. And then there's also a very tiny risk, and this is, you see it once in a blue moon, that things don't heal quite the way we want, and I have to go back in and do some more surgery to make it heal the way we want. It's very rare, but it's just something that's important to think about. Anything else I'm missing? There's other things will probably come out as we talk. So.
And I think those what ifs that you're saying, you know, it's like this is the panel, and in a way when we think about surgery with the young people, we almost want to prepare for them. What if? How will you feel if actually after your surgery your speech has changed and you need further surgery? If you don't, you don't. But if you do, how would you feel? So that you are prepared for not going into the surgery thinking everything is going to be perfect as I finish, because that's, you know, that might be the case for most of the young people, but it might not be the case for everyone. So we need to, in the pre-work, be ready for those what if you know, actually you thought it was going to change your life and it doesn't. It changed your profile. It doesn't change your life. Kind of be ready for those discussions so they're not a surprise at a time where you're already really, you know, drained for recovering.
And I think that's, and one of the things I will say to my patients is we're focusing here on the jaw surgery, but actually it's often part of a big treatment plan. And that treatment plan, from start to finish, if you're going braces, jaw surgery, then potential follow-up surgery for speech, lip, nose, a hole through to the nose, that can add another 2 years on afterwards. So you can be looking at a 4-year pathway to get everything done. Not all patients want that whole pathway or need that, but it's just an awareness that this may be the path that they choose. And I like to have that discussion with them beforehand so that they feel like they're moving along and things don't become a surprise afterwards.
How long does the actual surgery take? Or does it really like differ?
It varies from patient to patient. It varies as to whether you're doing 1 jaw, 2 jaws, whether you take bone from the hip. I personally have had a single jaw take me a couple of hours. I've had a double jaw take me 3.5. The longest it would take me is probably about 5 hours. Different surgeons, different speeds as well. But I like to have a good half a day so that there's no, so we're not rushing and we can just do it nicely. So it's not a short procedure.
Thank you for that. So this one is, next question is to you, Rachel. So when I have decided I would like to go through the surgery, there is usually a lot of preparation or orthodontic work beforehand. What are the next steps once I've agreed to it?
So once somebody's advised us they'd like to go ahead, we normally see them in the orthodontic department. We take some records, so dental models, so from impressions, dental x-rays sometimes in addition to that, photographs, so we've got baseline for planning. And then often it's to begin with, for most patients, fixed braces, so top and bottom fixed braces. Sometimes with orthodontic preparation you have to think about making space to straighten the teeth, so for some patients they need to have some dental extractions done. They're usually carried out by your own dentist or your general dentist shortly before we replace our braces. Most patients need orthodontic preparation to align the teeth, first of all for aesthetic reasons, but just to move them individually in each jaw into the right place so that when Kanwal moves the jaw they actually fit well together. On average we're looking at maybe 18 to 24 months worth of preparation. Depends on if you've had some braces already, so if you've already had a little bit, your teeth might be fairly straight already. And coming to see us about every 6 to 8 weeks. So it is a big commitment, and the braces remain on before, during and after. So there's a lot to do.
Sometimes also, if the patient's had a bone graft in the past in front of their jaw, we have to top that up as well. So, but that doesn't lengthen the treatment. It can be done at some point within the orthodontic treatment, but it does mean an extra stage of surgery.
And will I be informed every step of the way of what is going to happen as well?
Yeah, absolutely. Patients are part of the whole pathway. They're sort of leading their pathway really from the point when they decide what they want. You get to know your orthodontist very well, so you're nearly always on first name basis, and you're seeing someone really regularly over quite a long period of time, which is really nice. At various points we take new records and see, do we think we're ready? Are we ready to go back to see Kanwal to talk about surgery? And at that point, we tend to all meet together, don't we, and have a recap about, okay, we think we're nearly there orthodontically, so let's go back to thinking, what do you want from your operation? What's your priority? Is it improving fullness in the cheeks? Is it changing chin position? So for males, females, different patient groups, they have different priorities. So you're really a part of that decision making in terms of what we're going to perhaps plan for you for your operation. At that stage, it's a case of once you're on the waiting list, you'll be kept informed of when and hopefully have a fairly good idea when things will take place. But come to see us a lot, especially before surgery, so there are ample opportunities. A lot of patients will also see our psychology team.
Communication at this point is very important, because when we can see his anxiety level rising, when you come next to your day to surgery, that might fall in exam, because if you are exam or uni, we have some of our young patients that are really anxious about missing out on some exams because it's going to be a surgery day. So communication is really important. When you're ready, so you can't delay too long, but actually you can delay enough to not be in the exam month. So we have seen young patients that have taken a gap year because they find dealing with the anxiety of the surgery a bit hard. But if you communicate with your team, this is something that we are going to take, it's important to you, so we're going to take it seriously, that we know it can't be around, if you have your exams in May, it's best to plan for July, so I think we coordinate in terms of listening to you, and anxious, if you go to your surgery being very, very anxious about the disruption is going to lead to something very important, then it's not the best state of mind. So it's something we're really trying to work hard with, to make sure you know where you're at, and you can communicate with us. Things are worrying.
Definitely. And I guess as well, that communication is also really important to communicate with your university and employers as well about what's going on. So I remember that when I had mine done, it was in third year of uni, which is a fairly busy time. But actually what I found was by having the conversation with the uni, they were also able to offer support.
It's not unusual for us to help put all of it in writing for a patient. Actually, if they'll say, I want to give something to school or to university or to my employer, we quite often will collate a report, explaining why they're having it, what they're having it for, the fact that they'll need to come back regularly, sometimes for unplanned appointments as well, which is tricky with commitments, and explain that they'll need some time off afterwards, and just make sure that people are aware that they will need perhaps reduced duties or different tasks to do when they come back. So it's quite a common thing for us to do.
And I would say the pressures when you are a returning adult are even greater sometimes, because you might be the main breadwinner for your family, you might have childcare, there's a lot of additional things that might add up, and that we need to consider when we are supporting returning adults, in terms of what kind of stress level it can generate for for a person that has those commitments. There are numerous appointments for us in our service, so I don't know how it works in other service, but if you are going to have the orthodontic work for your jaw surgery, you need to come to here, and that can mean 2 hours to come here and 2 hours, so you're losing half a day to come to an appointment. That's part of what needs to be done, but we need to be to really communicate on that and share about this is going to be okay, or this is going to be very tricky, or I need my appointments later in the day because so that's the kind of things that, particularly with adult returners, we're always considering, what is the family situation, what are the impact, the impact on life, on work, on money, because they are serious matters.
I know you guys have said if I do have any questions that I can come to you at any point, but what if I have decided that I don't want to have the surgery, and what if it's like the day before? Am I still able to kind of make that call?
That's the point where I'd pick up the phone and go, Karine, I need your help. So
It does happen.
It does happen, and I think if a patient the day before their surgery suddenly went, I don't want this, I suspect that's probably around anxiety. It's not the actual that they've really changed their mind about what they want, it's just they're faced with something that is big, and they're going, I'm not sure I can go through it. And that's where...
Yes, absolutely.
Yes.
Yeah, I would say, hopefully there's enough communication so that we would capture if someone actually wasn't quite so sure, follow the process, and then went, well, actually, no, I now see what it entails, I don't want to do it. We haven't mentioned smoking is an issue as well, so you have to stay away from smoking the entire time, and sometimes you find that people might have life stresses and they had stopped, they take back and they say, I need a pause in all that. Hopefully you're not near the time where you're having the surgery. Near the surgery, as Can will say, is more likely to be anxiety, so we might have then a delay of a couple of months, so we have the time to think about what it is that's going on for you at this point in time that that thing you've been working on for 2.5 years, suddenly as you come into the, to the ward or the evening before, it's too much. And
we've really had anyone do that though.
No, we would have cancellations 3 weeks before. We had some, but actually then it makes sense. Once you sit down and think with the patient, it makes sense. Why was it too much at that time? And usually with a bit of work and strategies around anxiety and communication with the team, the next schedule is actually going ahead. So it's okay. It's okay to have this realization it's going to happen. It is a bit like you waited for something, and then actually it's the day you jump, and that's an enormous thing to do. And there might be various factors why it's too much at that point in time. So normally we know the team jump in, we have some strategies and sessions, and then we can proceed. We should be able, as a team, normally to pick up who is not so sure, is having a change of mind as the process happens. And family circumstances change as well. And I think it's a time in life where these young people or young adults, things happen. So there might be unexpected things that are going on, and they might need to hold. And hopefully it's more, towards the beginning, or they made a decision and then it's like, well, but actually I'm now taking a gap year and I want to travel the world, and it's like that doesn't quite fit, so should we delay? So it's kind of those discussions, it's not because you made a decision at 15 for something you're going to start when you're 16 or 17 that actually you realise, well, I'm going a different way than what I thought, so we might have some...
I would say one of the conversations I do have with patients is about how much they want treatment. And if I have a patient say, I'm not sure, do you think I should have it done? My answer is, if you're not sure, no, you shouldn't have it done. Because it's a big commitment, and if you go into it not feeling, not understanding and not really wanting it, it's actually a very difficult commitment. And that's when we would have a problem nearer the time where someone goes, actually I'm not sure about this. So I would rather a patient comes and has the conversations early, and we put all the options out there, and then if they're not sure, that's fine. We put it on hold before we do anything that we can't change or would be problematic to change. And usually that means we don't tend to have that many patients changing their mind within treatment once they've started their orthodontics. They usually have their pause before we get the braces on.
I think if you're in the course of your orthodontic preparation, what we inadvertently do is we make the bite a little bit worse before the operation can make it better. So patients will find that their bite gets even greater or larger. So it's a huge thing when they turn around and say, actually I'm rethinking. It doesn't mean that they can't reconsider treatment later. We do get patients sometimes who, for various reasons, take a break, take a pause, and we take braces off and we give you retainers and we hold things and wait and see, and some patients accept and some patients come back later and say, actually I have thought about it, I would like to resume treatment, and then we spend lots of time talking to them about.
And I would say the patients that sometimes find it the hardest to really want it is the patients that are coming because they don't have a complaint around their profile or their jaw. They want their nose changed, for example, or something on the lip, and then they come for something, and then in order to achieve best results, it looks like the jaw, movement of the jaw would be advisable. And then it's this huge, bomb. It's like, okay, you want that, but we're going to offer 3 years of that before. That's a huge. I mean, we've seen some 15-year-old going, I just want, thought maybe in the future this, and then you end up having this 3-year pathway thrown at you, that. It's huge in deciding. It's really huge when that wasn't what you came for. The ones that come and say, I really can't chew my sandwich, usually you would have less difficulties because they know exactly why they want to change. But when you came for something else, and then you are offered the way to there is this long thing that is going to take 2 years or 3 years of your life, that's a different adjustment, and that's when we can have a longer decision making around the jaw surgery and change your mind sometimes.
Yeah. And then, so this next question is for Kanwal and Arthur. So are surgeons able to tell or show me what I will look like after I have the surgery done?
There is software available that we use for patients across the board that can in a combination between photographs and x-rays, either in 2D or 3D, can show changes. However, it's a big however for cleft patients.
Yeah.
That modelling, the way that the computers work it out, is based on non-cleft patients. So that data isn't really there for patients who've had a cleft. And if you've got a patient who's got scarring in their lip, it reacts differently in every single patient. So I have to be honest, I don't really like doing before and after modelling for a particular patient and saying this is what you'll look like afterwards, because I can't guarantee that. I can give an idea, but I can't guarantee it. What I would rather do is show before and afters of other patients when they've agreed to it, because you can show these are the changes we can make and they're real. So there is an element of trust, I suppose, in what we do, that we know we're going to get changes and we should get good changes, but the actual predictability of what happens with the soft tissues is difficult.
Yeah, pretty similar to what Kanwalraj was saying. Going in, we can actually show the before and after of me, like a directly link to the BRS, a website, the British Orthodontic Society. So they've got a great article on what dual surgery is, what it entails, and gives examples of other patients, obviously like on cleft, who have actually gone through this situation as well. So you actually able to see imagery on the website of before and after. So I think even that is pretty much enough, because that kind of highlights what the treatment is and what you could potentially look like. But yeah, in answer to your question about cleft patient, they can't show it.
There's certain things we can perhaps predict for certain patients that we might expect. You move the top jaw forward, sometimes the tip of the nose elevates a little bit, and for a lot of patients that's a good thing. So there are certain jaw movements that we can give you a good idea of what you might expect change-wise for you, but exact specific outcome, this is what you're going to get. It's very, very challenging.
I think thinking around, like we were just talking about nose is actually one of the, or patient dissatisfaction with how their nose looks is often one of the leaders into jaw surgery. That they'll come to me and say, I don't like my nose, and I'll go, okay, I can change your nose, but your top jaw is small, so your nose will never quite be in the correct position. So to get a more ideal position, this is what we do. But when I do the jaw surgery, I'm moving effectively. I think of it like a house, where the jaw is like the walls of the house and the nose is like the roof of the house. If you move the walls, the roof is going to move as well. And that's what happens with the nose. So you always get a change in the nose with the jaw surgery. And that can be some widening. It can be that the tip will come up, and that can be beneficial. But in some patients, the tip doesn't move, but everything else does. So actually the nose becomes flatter. And I can't predict that before the surgery. So what I will say around nose is, the nose will change. Is it going to be a good change or a bad change? I can't say. However, what I can say is that if you don't like it, I can offer you something further. And that's what we were talking about, that sometimes you have an extra step of surgery.
And I think psychologically that's really important to prepare for, because if all started was the idea you had about how you want your nose to look like, it might be such a long time before this happens. And even when you have the surgery, it might get in a direction, even further away from what you like before you can get, 6 months at least later, your nose surgery. So if you think about life events, I think in terms of keeping your mood up and getting, keeping motivated towards the surgery, it can be a lot of work, and you can have really a journey to your nose surgery that can be like that, and when you had your jaw surgery and you saw and you look and it's still not what exactly you wanted, you drained, you can have days that are going to be a bit low. That's part of the journey as well, to have this kind of up and down towards what you wanted, and I think that's important to be prepared for it.
I think it's sometimes, from my point of view, it's slightly easier if I've got a patient that's coming in and saying, I know I want nose surgery. We can prepare for that in the plan. I know I'm going to see them at 5 or 6 months after their osteotomy and go, right, what's next for you then? The ones that maybe are a little trickier are the ones that weren't sure which way they were going to go, and then they come back and say, actually, I don't like my nose, and that can sometimes give a little bit of a delay in when they get their surgery. But there has to be choice, that, you know, and also it's always good to wait a little time to let everything bed in and see how they feel about themselves as well.
Because we have, in a way, to remember that none of that surgery would happen if it wasn't in a response to a dissatisfaction or a complaint that the patient had. So there is something objective, but that something objective hasn't got to be corrected. It hasn't got to. So it only is if there's an objective from the patient. If the patient has a name that I want to change this, and therefore you're hanging on to I want to change this. What happens when you have a 3-year delay in changing this? Or if at the end this is not what is exactly expected? How we tolerate that? How we work around that?
I think that also leads into something else that's really important. That if a patient says to me, what would you change? I actually feel quite uncomfortable about that, because my ideas of beauty or averageness or what I like could be very different to what the patient likes. So when a patient actually comes to me and says, these are the things that I don't like, or I want a nose like my mother's, or and they're quite specific about things, it makes it a lot easier for me, because that's what I aim to change. Whereas if someone comes to me and just gives me a global, I don't like it, the problem there is I could do it to how I like it, but whether that matches what the patient wants is different. So that conversation around specifics is really important. And also that patients shouldn't be scared to ask for what they want, because this is a line I get quite a bit. Oh, I don't like this, but I know nothing can be done. And it's like, hold it. Come to me, ask me, because you might be surprised. I might be able to say, yes, actually, I can do something for that. Sometimes I will say, no, I can't really do that for you, or actually, I can't see what the problem is. So in my eye, I can't see it, so I can't change it. But frequently, they'll come and ask me, and I'll say, yes, I can do that, but I may need to do this, this, and this first, or I may need to wait a year or two. So asking the question is very important.
And I think for the teams, it's almost, I would say, a tricky balance sometimes, because, as you say, you wonder what a certain patient would like change, but there are other patients that 15 years of the time where we see everyone, there are certain patients that are going to come and you know exactly what you could change, you know exactly all the things that you could do. But actually that patient is coming and saying, I'm so happy with everything, and everything is fine. And I think we often have debates as a team about, at that point in time, do you tell them, it's great, you know, really good that you're happy, you know, if ever that's to change, or if you have these are the kind of things I could do, it's really hard to have that balance between, do you feel you're not informing the patient about what they could have done, what's available, but actually, do you want to give them those options when they're telling you life is perfect and I'm so happy? I think it's a real hard balance, and I think the teams are we continuously working at it. I don't think we found the right recipe yet about what we mention, what we say, what we don't say, between raising alert to something that the patient wasn't really aware of or doesn't matter, or feeling that we haven't given them the appropriate information. I think we're still sitting somewhere.
It's a tricky one.
It's really
very fluid conversation, which can be very much driven by the patient. So, like you said, your notebook where you write your questions is really important, because sometimes you come in here, and if we've got a big clinic with lots of different professionals in it, can be quite intimidating. So having that notebook and that reminder and saying, actually, I wanted to ask this, or this is what I don't like, is really helpful.
Now, can you kind of walk us through what happens on the day of surgery? Because as we were saying, this may well be the first kind of operation someone goes for as an adult, and so it could be a little bit different to their memory as a child.
I think it will vary slightly from hospital to hospital. We have moved, I think, as a whole in the NHS to coming in on the day of surgery rather than the night before. Big change for most patients is they're going to be on an adult ward rather than a children's ward. Occasionally we can sneak the odd patient into the children's ward into a side room, but that's unusual. And
it will be need-based as well. It would be based on their needs, their particular needs.
Yeah, so, and anyone who's over 18, we definitely can't do that. So come in on the day of surgery starved, so that means nothing to eat or drink for 6 hours before the anticipated time of surgery. Come to theatre. Well, they see the surgeon on the day. We always have a last minute chat, confirm everything's okay. See the anaesthetist, then they'll go to theatre, be anaesthetised, go to sleep, have the surgery, and then when they wake up it will probably be in recovery. Once they're in recovery, I would usually go and visit my patient in recovery, see how they're doing, and then if they've brought parents with them or someone with them, we would usually call them to come to recovery to see the patient, make sure everything's okay. One of the things I usually ask my patient at the beginning of the day is, do you want me to discuss your operation and your care with your family? Is this something you're happy for me to do? And the reason I ask that is most people want to know what's happened, and once they've woken up from a big operation, they may have a chat with me and it may seem like they can remember everything, but the next day they can't. Some patients will remember absolutely every single word you say, some won't. So I think it's important that they have another source of information that's there with them that could say, yes, I've spoken to the surgeon, it was okay, or this was a bit unusual, or these are the things that were done. But it's to give them reassurance that someone else has that information rather than just relying on the staff. Because actually, at the end of the day, I'm going to go home overnight, so I may not be there to be able to have that conversation with them when they're a bit more awake. So it's important that that information gets to them in a nice way. So that's why I like to talk to parents as well.
That's a really important thing you're mentioning, is the fact that during that process, if the process starts at 15 and ends when you're 19, during that process you would have gone from being the communication and the phone calls and the letters are going to parents, because the parents are your parents and guardian, and in the meantime you become then you're medically responsible, and suddenly when the team calls or the parent call, we can't exchange, we have to have consent from the young person to be able to talk to the parents. Some parents find that very, very, very difficult because they kind of lose this right to knowledge or this right to contact at a time where their child is going through one of the surgery, which is one of the most major surgery. So that's really important what you're saying in terms of preparing that and having that discussion in advance. Because on the contrary, you have some youngsters that will not want, in terms of how families are working, will not want anything shared with their parents. And as soon as they can have, the control over their medical discussions, they come by themselves or they want that by themselves. You really have to tailor it to the family.
It's a very interesting transition time, generally, isn't it?
Yeah.
And it's important to have discussions around that. So, but then, yes, so recovery, then back to the ward. As I said, usually the first night, sleep. Drink water, sleep, maybe watch a bit of telly if you're really awake, which is unusual. And then next day I'm usually like, right, up and out. Come on, out of bed, have something to eat, have something to drink. Have you been to the loo? Those are the standard after you've had an operation type thing.
Yeah.
And like I said, some patients do really well and they want to go home the next day. Home is a nice place to recover.
Yeah.
But some patients need to stay in a bit longer. They need a bit more pain control, or maybe they're struggling with their eating and drinking. And we just have to sort of tailor it to that individual, and that's fine. I tend to do my operating on a Friday, so hopefully I get my patients home on a Saturday. But if they don't, sometimes we'll keep them on Monday, because then they come back to see our orthodontist within a few days of surgery. So rather than sending them away when they're feeling tired and then bringing them back for a long drive back in, we say fine, just stay. It's a bit easier. So then the next step would they come and see the orthodontist after they've been discharged to see how the bite is and what's just the next steps.
Yeah. Sometimes we'll take some dental x-rays, but we're really looking to see have we got that bite we're expecting. Usually we've got feedback from our surgeon about how it all went and that they're very happy with how the surgery went. Often for patients we'll use orthodontic elastics to help guide that new bite and show patients what to expect and do a lot of TLC and how to look after things and what to eat and how to care for them out.
Definitely. I mean, my memory of it was a fairly busy first few days. Seeing lots of different people, lots of stuff breaking, lots of broken sleep as well. but you know, obviously Arthur, you've been through this
Doesn't
more
match what
recently.
you doesn't match what you've experienced.
So, you know, can you tell us kind of what the first few days in the hospital and at home were like for you?
Yeah, so obviously I came in on the Thursday, had the operation, got discharged on the Saturday, so it was a pretty quick turnaround. In terms of the procedure, yeah, I remember when I woke up, you know, I was in my room, felt slightly a bit delirious, you know, around what's going on, but that only lasted for a short while. And also I remember there was a lot of soreness, and I think my sister and my mum were with me, and the first question I asked them, I go, look, could you just bring a mirror?
Yeah.
I can only see myself like, straight away. And nothing else came to my mind, you know, in terms of, I just said, just show me a mirror. And the thing is, I couldn't really speak because obviously, so luckily there was a notepad and I just kind of wrote it down. But I felt so much fatigue that by the time I actually finished writing down what I did, I slightly just fell back asleep again, you know, kind of woke up. And you're like, okay, so then I think that was the first question that came to mind. In terms of ongoing kind of, you know, day-to-day activities, so when I was in hospital they also gave me painkillers on a regular basis and antibiotics as well, because also when there's a lot of scarring, you can prevent the risk of infection. And in terms of diet, we talked about soft diets, obviously wasn't able to kind of chew, so 46, which are really great drinks, and they kind of gave that to me, so I was kind of thinking on that pretty much for the whole day.
Remember those?
Yeah.
So we'll bring it back.
They're really good.
Do you need them with cream?
It could bring you back.
They're like a whole meal replacement, aren't they?
Yes.
So you're getting lots of calories, really high calories, because you know, we don't want you to be chewing at that stage. So
Yeah, and I remember like during lunch, I mean, you know, you get the person come in, they go, would you like anything for lunch? And they kind of gave, you know, there was soup on the menu, but even with that I was struggling. I just wasn't able to do it. Yeah. And I think, so then also I got home and then I had this cooling mask, which was given by Hyotherm, and that's Professor Hayes, who's the person who actually performed the surgery on me. It was something that he was trying out for his patients, and he said it's a really good device. So I actually started utilising it during my sleep. So when I needed to go to sleep, put the mask on. It was comfortable as well, it didn't really irritate.
and it's a cooling mask, isn't it?
It's a cooling mask, so it kind of helps with the swelling. And yeah, kind of first week or so, it was pretty much, you know, soft diet. You know, kind of spending your kind of how to utilise your time is pretty difficult, but kind of, you know, watching television. Staying active and mobile was the take-home message for me, because the nurse who actually first admitted me in, who actually performed all the general kind of checkups and everything, that he could say, look, you need to ensure post-surgery if you can. Obviously, you need to rest and everything, but just try and get up on your feet as soon as possible, because you know, you're already going to be in such a kind of low state anyway, so sitting on the couch all day won't help either. So kind of helped me with my recovery.
I know we've spoken about it a fair bit, and you've mentioned it there as well, but that tiredness element not to be underestimated really, because you know, I remember as well, like people would come and see me in the hospital, and I start talking to me, and I just doze off, and it's like, you know, you feel, you worry you're being really rude, and it's like, you know, and you've not got the normal facial expression either that you can give that to people, and it's, yeah, I don't think I've quite experienced anything quite like that kind of tiredness that I just could not power through, you know.
I think it's something that actually, as a medical team, it's very easy for us to underestimate, which is how difficult, what is recovery like, and it's, you like you said, you just get fatigued and your energy requirements are higher, and even if you are eating more, it still doesn't quite break through that need to rest and sleep, but then you have to balance it against, actually you've got to be a little bit mobile to keep yourself well. But it's about being realistic that your ability to do things will be reduced for a period of time.
And that's why the care, being cared for, you know, you talk about your sister and your mum being there, so I don't know if you returned to, you know, to the home where they were your mum and sister, but actually that's the big thing with adults. At that point in time, you need to be cared for. So you need to have people around that are going to bring, be there, the soft drinks and the painkillers help, if you need more. So you need really to be in an environment that you're going to have some support in. So therefore, the young people still quite naturally, most of them, but not all, would have that. When you're an adult, and you're the one who care for yourself, that can be a trickier recovery, because you don't want to go and prepare something, yummy and smash, and mush it and do all of that. It's much nicer to be cared for. So sometimes that is something that we have to think in advance about how is that going to happen. Who's going to look after you? Because the concept of being looked after might not be as easy as when you reach a certain age. So that's something we need to think about, because that time is really crucial. The recovery time is really crucial.
Definitely. And what sort of follow-up care, will people receive from the Cleft team after the surgery?
So you'll tend to meet, with the way we work it here, is you'll see the orthodontic team, usually either the following day or the couple of days later if you've had your operation on the Friday. And we work so closely together, if there's anything that we're perhaps concerned about, you would immediately have some contact with your surgeon. So your orthodontist will be seeing you regularly, maybe first few weeks, every week, every other week, and then you're back into sort of normal orthodontic adjustment intervals. You'll normally have an opportunity to see the patient.
Yeah, I'll see usually a couple of weeks in, about 6 weeks in, and then that gets us through what I think is the acute healing stage. And then after that we move back into finishing the orthodontics, and then I see again at around 6 months, which is the what next stage? Is there anything next? And then we review again at a year and 2 years just to see if everything's stable. So, but the main bulk of the appointments are in that first sort of 6 to 8 weeks after the surgery. And actually we would encourage that if there's any concerns or worries, that rather than leaving it, you phone us and you come back to us.
Definitely. And I think that's really useful information, and what we've been speaking about is just asking those questions. I think that is about all we've got time for on the panel discussion this month. But I think the key thing that there is a lot more obviously that could be discussed, because it is a big topic, as we've been saying. It can be quite a lengthy pathway, so just keep asking questions as you go, making sure that you've got the right expectation of what's about to happen.
I think the other thing is just in terms of general resources, as Athar mentioned, there is the British Orthodontic Society website, and it's your jaw surgery. Your jaw surgery. That section is specifically for patients, so it's got patient stories on it. It's got before and afters. There's an area about eating and drinking, what you could, so diet sheets, things like that. So that's actually a really good resource that a patient can just access directly themselves if they've got any quick things that they want to know.
And we recommend that their families and their carers will look at it as well, because there's a video diary of a young man who's had his operation, and you can see him from day 0 all the way through this sort of 6 weeks recovery, and you can see how initially quite swollen and it gets better and better. So it's so important for your carers to have an idea of what to expect, and I guess you took a bit of time to get used to sort of seeing the change and recovery, so it's a brilliant resource.
So we'll make sure to put all those links that we mentioned into the links for this podcast. Well, as I say, that is all we've got time for. We hope that everybody at home who's been listening or watching this has found this discussion to be helpful in helping you to make that important but very tricky decision about whether or not to have orthodontic surgery. Remember, of course, that you can access more information and listen again to this and other panel discussions on our website at www.clapper.com/adult services project. If this discussion has made you wish to seek support and you're not currently under the care of the Cleft team, please do contact your GP and request a referral to the Cleft team. You will find details of the local Cleft team on our website. And alternatively, if you are already being seen by your Cleft team, do feel free to talk to them about the content of this panel discussion and any questions that you may have. I would like to thank very much our panellists, Kanwal, Rachel, Athar and Karine, for joining us for today's discussion, as well as a big thank you to you at home for joining us as well. Make sure to join Nicky and myself again next month, where we'll be in London helping you through the highs and lows of the festive period in our Christmas special. But until then, thanks again to our guests and to you at home. Goodbye for now.
Bye.
Hey guys, thanks for tuning in. We want to know what you thought of the programme so that we can make it even better for the next one.
So go ahead and give the video or podcast a like, and if you're watching the video, comment below and let us know what you think. If this was interesting, make sure you subscribe to our podcast and videos.
Our next podcast video is coming up at the end of the month, so check out www.hacker.com/panel discussions to find out what we'll be talking about next. You can also watch this and other panel discussions again on our website.
We want your questions to take to the panel. Visit our panel discussion page on our website to submit your questions.
You can also check out everything we're up to with the Adult Services Project, including a list of our upcoming programmes and events at www.clapper.com/Adult Services Project.
And make sure to also follow us on Twitter and Facebook. We look forward to seeing you again soon. Bye for now.
Bye!